Welcome to this video on aspects of the face, where I'm going to be talking about facial landmarks, the scalp, different layers of the face, and going to a little bit of like an introduction to the muscles of the face and the nerve supply to the face. So yeah, let's start. So why is it even important for us to know about like different landmarks or different features of the face? Well, it's because as dentists, when a patient walks into our surgery, not only are we going to be doing intraoral examinations where we look into their mouth, but we're also going to have to examine external factors, so just the outside of their face. So for example, if a person has swelling on their cheek, that could indicate something, so we need to be able to identify these. We can also use facial landmarks as reference points for recording notes or writing reference. So that means like if you want to kind of say that there's a cut on their lips, we can use different facial landmarks around that we already know to like record it in our notes, so we can say that right next to the vermilion border there's a cut. So when other dentists read it, and also when you look back at your own patient notes, it's very easy for you to identify exactly where you're talking about, or yeah. And so it's also really useful to know for things like reconstruction and cosmetic surgery. So we might have to do jaw correction surgery as dentists, and other medical professionals will do like cosmetic surgery, in which people would want their face to kind of either be reverted back to normal if they've been in accidents, or maybe enhance their facial features. And you may know this before, but the golden ratio is 1 to 1.62. And those like kind of say that that's your perfect face. Like that's a perfect face. Those are the perfect like ratio for features. And yeah, so if you ever want to like reconstruct a surgery, it's really useful to know what the face should look like. So when you do reconstruct it, you know, your patient will be happy. Okay, so as noted by Leonardo da Vinci, the face is actually split horizontally in thirds. So this is a third, this is a third, and this is a third, and vertically into fifths. So we have 1/5, 1/5, 1/5, 1/5, and 1/5. So it's just a very symmetrical way. And obviously not everyone's faces are going to be like this. Most people's faces aren't symmetrical. Even this like a random person I got off the internet, her face isn't symmetrical either. But so like it's not anything to be obviously worried about, but it's just kind of an easy way to map out where your facial features should be. So if we start with the horizontal ones, so we have the beginning of the third actually starts here at your tracheon, which is your hairline, and then ends at your glabella. Then we have your glabella to your subnasally, which is below like the septum, and then from there to the menton, which is kind of the like below your chin. And we'll come back to this actually when we learn the names of them, so we can easily identify where the fifths and where the thirds should go. But yeah, okay, this is the same face. Now we're going to annotate it, and we're going to add all the different facial landmarks that we should know on there. Okay, so the first one is the hairline, and this is called the, sorry, let me do that in a thinner pen. This is the hairline, and this is called the tracheon. Next, going down, we have the glabella, like I mentioned before, and this is in between your eyebrows. It's called the glabella. The next thing we get is the inner canthus of your eye, which is like the inner part of your eye. Inner canthus, and the outer canthus, which is just the outer part of your eye. So those are there. And if we also go down, let's look at the ear now. We have two parts of the ear which we need to know. The top tip of the ear, which is called the pinna, and you know the little skin-like flap attached directly to your face, like here? This is called the tragus. Next, let's look at the nose. So the very like edges of your nose here and here, these these are called the ala, and then the inner part is called the nares. So we have the ala, then we have the nares, and just below that we have these ridges, which you can like see on yourselves, and these are called the filtral ridges or the philtrum. Then the outer part of your lips are actually something called oral commissures. So those are oral commissures, and the border between your lip and the skin of your face is what we call the vermilion border. And a quick fact about this, which if asked, like you may want to remember, is that the epithelium, so the histology, the epithelium of the vermilion border is thin and lightly keratinized. Okay, next we have, just below that, we have this little depression here that you can see just under your lip, and this is called the mentor-labial sulcus. It's named that way because like if I say here, this is your menton, it's where your mental foramen is, but that's where your menton is, just the bottom of your chin. So the mentor-labial sulcus, obviously the labia refers to lips, so, and then menton is kind of the chin, so it's just the depression or sulcus in between. So yeah, so now if we go back here, we can see that the thirds are divided by the trachyon to glabella, glabella to subnasal, and subnasal to menton. Then the fifths are from your pinna, your pinna to your outer canthus to inner canthus of one eye to inner canthus of the other eye, or you can also do the two, the alas. Then we have the inner canthus again to outer canthus to pinna. So yeah, that's how your face is divided and into like different ways. Okay, now let's look at the scalp. I'm actually going to show you this picture just because it's going to help you understand it a little bit better. But the scalp is made up of 5 distinct layers, and it's not just like skin with hair on top of it like most people think it is. So the 5 layers of the scalp are the skin on top, which everyone knows. Then just underneath that we have the connective tissue, and it's dense. Then we have something called the aponeurotic layer, and an aponeurotic layer is just like a connective fibrous band layer. It's quite thin and it just connects like either muscles or different tendons together. It's just like, think of it as like a tendinous band. Next we have the loose connective tissue layer, and right at the bottom we have the pericranium, which attaches directly onto the bone that you can see here. So it attaches directly onto the skull. So we can see that our thickest layer is the dense connective tissue, and then our next thickest layer would be the skin, and then as we go down and work our way down, we get thinner and thinner from the aponeurotic layer to the loose connective and then the pericranium. So yeah, that's the anatomy of our scalp visually. If we actually think about what this means, so the first layer of the skin starting from the outside, so of the scalp, is our skin starting from the outside. Our skin has sweat glands on it. It has hair follicles. It has good blood supply, which means it has like some blood vessels. And it has good lymphatics, which means that it's just like lymph nodes and stuff like that, so good drainage. The next layer is the connective tissue layer, and this layer is thick and vascular. Vascular means good blood supply again. So if you see the word vascular, it just means it has lots of like blood vessels. So it has lots of like blood vessels going to it and going from it. Next we have the aponeurosis layer. And like I said before, this is a broad and strong tendinous band for attachment to muscles. So for example, the frontalis muscle is here and the occipitalis muscle is here. So the frontalis muscle is on the front of your skull, and the occipitalis muscle is at the back of your skull. And there's an aponeurosis, so there's a band of fibers that connect the front to the back of your skull, and this is like what an aponeurosis is. It connects like muscles groups, so it gives attachment for muscles. Next we have the loose areolar connective tissue layer, and this allows for scalp movement, so it allows your scalp to move. So if you like touch it and kind of move up and down, that's because of the loose areolar connective tissue layer. And this also contains lots of emissary veins to the meninges. Finally, we have the pericranium, and the pericranium, all it is, it's just attached to bone. Okay, now there are some important things that we have to consider for this. Okay, so like I said before, we need to think about certain clinical elements, to do with obviously your face, and that's why it's important, our scalp, and that's why it's important for us to know this. So, if we pose a question, so where is the main blood supply in the scalp, and why do scalp lacerations bleed so much? Lacerations means any injury to the scalp. So where is the blood main supply? The main blood supply is in the connective tissue layer, and the pull of also the occipitofrontalis muscle can cause a wound to gape and open up further. And also the blood vessels are adhered to the dense connective tissue. So if we have the blood vessels here, we have dense connective tissue on this side and this side. And naturally this means that there's not much kind of movement that can happen for the blood vessels, so it can prevent vasoconstriction, which means that you'll get more kind of blood, more bleeding and stuff like that. And the blood supply to the scalp is made up of many anastomoses, and anastomoses are just a cross-linking of different fibers or different kind of connections, and this leads to profuse bleeding as well. Just something to note, the blood supply to the scalp doesn't actually lead to bone necrosis, which is kind of the degeneration of bone, because most of the blood supply to the skull itself comes from the middle meningeal artery and not from the scalp. So just because you have an injury in your scalp, you're not going to get bone necrosis, don't worry. Okay, another thing we need to consider is which layer of the scalp is the danger area for the spread of infection and why. And this would be the loose areolar connective tissue layer. And this is because pus and blood can spread easily, and they can actually pass into the cranial cavity via emissary veins, because emissary veins travel from the outside of your scalp all the way inside your cranial cavity. They can go inside and spread into that, and they can obviously carry pus and blood and infection to them, because they connect the extracranial veins of the scalp to the intracranial venous sinuses. And also, because emissary veins can go directly to the meninges, which is a part of your brain, infection spreading from the scalp to the meninges is a meningitis risk. So you can get meningitis. Okay. Next, let's look at epidermal appendages. And this just means anything on your skin or within your skin. So different like particles and stuff like that within your skin. So we definitely know hair follicles. Hair follicles originate deep within the dermis, and they're directly connected to blood vessels, and they also have a close connection to nerves. That's why if you do things such as hair removal, like waxing, it's quite it hurts a little bit, it's quite sensitive. And yeah, you can see the hair follicle here. And also, an oil gland, or something known as a sebaceous gland, is directly connected to the hair follicle. And sebaceous glands are just oil glands that are found all over your skin, and they produce something like some oil known as sebum. And yeah, you may have heard of sebum before. It's just a certain type of oil that you can get on your face, on your skin. So these are directly connected to the hair follicles. Also, you have things such as sweat glands, and only in mammals or in like humans, you get nails that are considered epidermal appendages. So yeah, those are the ones we need to know about. Okay, next let's look at the layers of our face. So starting from like very deep within, the first layer of our face is bone, as we know our skull, our skeleton. And next we have muscle, and this includes like deep muscle and something we call SMAS, which is the superficial muscular aponeurotic system. A muscular aponeurotic system is, like we mentioned before in a few slides ago with the aponeurosis, it's just where kind of like muscles are attached or can kind of like link and move with each other. Because like say we have a muscle here, this is like the beginning of the frontalis muscle, it can connect directly to the occipitalis muscle via this aponeurotic layer here. And the muscular aponeurotic system is like a collection of fibrous muscular tissue aponeurosis, and it doesn't have any direct bone insertions. So yeah. Next we have something called subcutaneous fat. So just under our skin we have like fatty areas, and you'll just see on the outer part where your zygomatic bone are and where your cheeks are, so the buccal area is where there's like lots of fat. And yeah, so just under our skin we have fat, and then we have muscle, and then finally we have bone. We can see this in a little bit more detail in this image, where on our outside we have our thin layer of skin, then we have our fatty layer here. Next we have our muscular aponeurotic system. You can see the muscle here, then we can see the aponeurosis fiber bands. Then between them we have the retaining ligaments and just free space. So it supports the weight of your skull, and it's not all completely dense and packed and not completely heavy. And then finally, sorry for my voice, finally we have the periosteum and the deep fascia. And this is just like your deep muscles and your deep skin here, just below the bone. Remember, periosteum connects directly to the bone and the skull underneath. Okay, like I'm going to do a separate video on each of the muscles, like muscle groups of the face. So I'm going to do a separate video on the muscles of mastication and the muscles of facial expression. But in general, all the muscles of the face, like you can see here, are all striated muscles, which means they have like cross-links and they're all like striations. All their fibers go in kind of one direction. And there are actually two types of muscles like we talked about before. Superficial muscles are not directly attached to bone, and they include some stuff such as the superficial muscular aponeurotic system. And we have the deep muscles, which is, so we can see here, we have the superficial muscles, including the SMAS, and the deep muscles here. And the deep muscles are behind the superficial muscular aponeurotic system, and they can be attached to the facial bone underneath. And these integration of these muscles of facial expression within the SMAS, so like we said, the integration of this is what makes the movements of our face fluid and not like stodgy and not like staged. Okay, so now let's finally look at the nerve supply to the face. The nerve supply to the face is actually provided by two nerves. One of them is the trigeminal nerve, so they're both cranial nerves, the trigeminal nerve and the facial nerve. We're going to start by looking at the trigeminal nerve. So the trigeminal nerve supplies the muscles of mastication, and it innervates the muscles of mastication. And it also provides the sensory innervation to the skin of the face. There are 3 divisions of the trigeminal nerve. It's a very important nerve. Let's ignore these for now. But the 3 divisions are the ophthalmic division, right at the top. Then we have the second one, V2, which is the maxillary division. And finally, the mandibular division. Now, the mandible is here, but actually the mandibular division, V3, spreads all the way up to your ear and your temporal lobe as well. Okay, so V1, or the ophthalmic division, innervates the area above the upper eyelid and the nose, and it supplies the face as the supraorbital, supratrochlear, infratrochlear, external nasal, and lacrimal nerves. So these are like within V1, within ophthalmic division, these are the just different nerves. You don't really need to remember them. Next we have V2, which is the maxillary division, and this innervates the face below the level of the eyes and above the upper lip. And this supplies the face as the zygomaticofacial, zygomaticotemporal, and infraorbital nerves. So that's like here. Then we have V3 mandibular, which is quite important as well. And this division innervates the face below the lower lip and supplies the face as the auriculotemporal, which is going up here, or which is like ear and going past our temporal, the buccal, which is the cheek, and the mental nerves, which go down here. And something that like was in the notes, but I wasn't really sure whether we really need to go into a lot of detail about this, was the parasympathetic nerve supply to the face comes from the cranial parasympathetic ganglia, whereas the sympathetic nerve supply to the face comes from the superior cervical ganglia. So maybe just memorize those, but don't try and go into too much detail about them. Finally, we also get our nerve supply to the face, or in specific to the muscles of facial expression, whereas here we got to the muscles of mastication, which is muscles of chewing. So muscles of facial expression. This is supplied by the facial nerve, and it also supplies taste as well as facial expression. It also supplies like taste and stuff. So the facial nerve actually courses between the SMAS, or the superficial muscular aponeurotic, and the deep fascia here, before its branches will then innervate, obviously, the facial muscles. Now, the facial nerve will come through the stylomastoid foramen, and it will appear like just behind and actually go through the parotid gland. So it will enter the parotid gland and gives rise to 5 main terminals. These are the temporal, the zygomatic, the buccal, the mandibular, and the cervical. Cervical just means neck. So those are the branches. If you just know the names of the bones underneath, it's quite easy just to remember these branches. These will innervate, obviously, the muscles of facial expression, and they will also innervate the digastric, posterior belly, and the stylohyoid muscles. So those are neck muscles, which we'll go into a little bit detail. Okay, what is the influence of the facial muscles? Now, facial muscles can actually influence distant anatomical areas, so anatomical areas which are a little bit further away. So, for example, the occipitofrontalis muscle here has a direct continuity with the eyelid innervator, which means that the pull of this muscle can actually cause the eyelids to kind of open up a little bit. So yeah, it just means that they're all kind of interconnected into one, which is like kind of why the fluidity comes from the SMAS level, which means that certain muscles can also influence other muscles. So from a clinical point of view, so let's look at the face and the neck. From a clinical point of view, an abnormal tension in like facial muscles could actually affect neck muscles as well. So if you have like prolonged tension in facial muscles, it can also directly negatively affect the neck muscles too. So yeah.